We did it.
Oh my gosh, it worked. I can't believe it.
I know. So easy. We figured it out, huh?
That was the funniest thing with the 1,000 followers.
I know.
I can't
It
believe you
hit
pulled
me.
that off.
I can't either. I'm very excited though that you got so famous so
That was
quickly.
crazy. I was like, I looked at that and I was like, wait a second. See, I thought I had 2 followers, but it turned out I really had 3.
Yeah, because I followed you back.
See, I didn't
So,
realize that. I thought I just
yeah.
had 2.
Yeah, well, man, you're doing big things in the world if you get 3 followers. So,
Well, that was a big jump, like 2 to 3. And then all of a sudden it
yeah,
was,
huge mungus. Exactly.
crazy.
So, um, for those of you that are just joining, this is Dr. Ben Rattray. Do you like Benjamin or do you like Ben? What do you like better?
I go by Ben, but here's the funny
Okay.
thing. I have to go by Benjamin online because there's a Ben Rattray in San Francisco who started change.org. So if you type in Ben
Oh,
Rattray, he's already
yeah.
taken my name.
Yeah.
But I
How
really
rude
go
of
by
him.
Ben. Yeah.
Okay, cool. Sounds good. Yeah, I did look you up on Google the other day and I was like, he is more famous than I thought. I
No.
mean, change.org, that is amazing. And
Oh,
I was like,
right. I
that's
know,
not him.
right? Yeah.
That's not him. Yeah, there's another Jen Hamilton out there who's on YouTube. And so yeah, I get confused for her sometimes too.
I know. I think I found her when I was trying to connect with you on TikTok.
Yeah.
I think I got the wrong person and I was like,
You're like,
wait a second.
this doesn't feel
That's
right.
not right. Yeah.
So we already have 133 people on my end. Um, and we've already got people talking about that I've got NICU nurses in here, a mama of a 23-weeker, another 23-week mama in here. So I'll probably get a lot of the comments on my end. I don't think you'll be able to see them on your end. And so I can intertwine some of the questions that I get on my end. Tisa is here. Hello.
Hey, Tisa. Awesome.
27. Oh my goodness, so many moms in here of babies who were in the NICU. Oh my goodness, so
That's
many.
awesome.
Holy cow. So the one of the questions is this likely to be a triggering for a NICU mom? So I don't think that we're really going to get into any like craziness, but I promise that Ben and I will both be, if we think that we're about to say something that's might be triggering, we'll try to do a trigger warning for you. So our goal with this live is just to kind of introduce you guys to Ben. So this is Ben Rattray. He is a neonatologist and board certified pediatrician, right?
True.
True. It's true.
True
And he
story.
has his MBA and he's a published author. So many things. So Ben and I actually work together. We won't say our place of business that we work just to keep everybody nice and nice. But he has written a book about all of his stories that he's carried with him in his heart. And he wrote them, put pen to paper. And so there's so many stories that we in healthcare don't ever get to tell. And I think it's super important and exciting to have this outlet where you're able to share some of the stories that you've held on to for so long, and finally have people that get to hear some of the miraculous things, the sad things, the crazy things that have happened. And I absolutely loved reading your book.
Thank you. Thanks so much.
Yeah. And my husband was making fun of me as I was reading. He's like, are you crying or are you laughing? Are you crying or are you laughing? Because you have some really funny stories in there, along with some really sad stories.
I tried to keep it light, in some of the
Yeah.
places, at least, when I could.
Yeah.
And the good
Exactly.
thing too is, we have so many good outcomes in the NICU.
Yeah.
So, there's sort of interspersed some of those really good outcomes. And then, of course, some of the outcomes are more difficult.
Yeah. And I want to put a plug. So he wrote a book called When All Becomes New. You can find it online, where pretty much any online books are sold. It is on Amazon. It's a really easy read. It's not a huge, big book that, you sometimes look at these books like I'll never be able to finish that, or it's going to take me forever. So if you're interested in reading something that you feel like you might be able to finish, this is a good one. And it kept me coming back too, because each of the stories aren't too long and they're just like, they suck you in so easily. And we've got somebody that bought it on Kindle. Okay, so yes, the name of the book is When All Becomes New. I do have it tagged in the link tree in my bio too. Okay, Ben, you ready? I've got lots of questions for you.
Okay, I am ready.
Okay, so some of these questions were sent in, some of these were questions that I had. And I listened to the podcast that you did, the Frontlines podcast that you did. I listened to it twice, all the way through, just to learn all about you. So some of these questions I already know the answer to, but I'm going to let you answer them for us. Okay.
Okay,
Okay.
thanks.
So my first question for you is like, what's your work experience? Like growing up, what kind of jobs did you have? How did you get to be in the NICU?
Yeah, that's a great question. So it turns out my mom is English, and she was a midwife. Well, she was first of all a nurse, and then she was a midwife in England. So she was actually almost like the real Meet the Midwife, like that series. Um, but then my parents immigrated to New Zealand, and she worked as a district nurse. So she would drive around all around Wellington City and see patients after they were discharged from the hospital, or do we Meals on Wheels, all that kind of stuff. And so I actually got to go with her sometimes. If I had a day off school, she would take me around with her. She was doing like PICC lines and IVs, outpatient meds, all that kind of stuff. So I think that was kind of my first entrance into medicine. Um, I think that's really where I fell in love. Although funny enough, in college, I started off as an English major and then kind of came full circle, ended up going into pre-med.
Amazing, amazing. And I listened in the podcast that you were actually thinking about being a neurosurgeon, which I feel in my head is such a different thing than neonatology. So what was it about neonatology versus the neurosurgery that kind of drove you that way?
Yeah, it's so funny. You like look back on your life and you think how different things could have been. You were asking about my first job, and I was actually a lifeguard as my first job in the pool. I qualified in the ocean, but because I have glasses, I couldn't do it.
Oh,
So ended up
yeah.
being a pool lifeguard. Um, and I initially thought I was going to be a firefighter, a pastor, or like a group home therapist for
Wow.
teen kids.
Yeah.
It's kind of funny to think back on those things because looking at my personality now, I'm not so sure that I would be, very good at any of those kind of things. But I read a book about neurosurgery when I was in medical school and just like fell in love with it, did a sub internship, thought that was what I was going to do. Um, and then somehow, by some sort of random chance, I ended up getting to do a sub internship in neonatology and just loved it. Like I loved, you get to kind of immediately work with your hands, put in a breathing tube, adjust vent settings, change pressure drip rates, like do all these immediate things. But the awesome thing is, unlike ER where patients are kind of coming through really quickly, in the NICU you get to develop these really long-term relationships with people. So for example, like a baby may be in there for 2 months or so, so you get to really get to know the family and take care of them over a long time period.
Mhm.
So I really loved that.
Yeah. That's amazing. And I was super interested in hearing, how you kind of like made that transition, because I'm sure in your heart you were like neurosurgery. That's what I'm gonna do. And then you go into that and you're like, wait a second, that's not, because that's how I went from ER to L&D, was that I always had my heart set on ER and I did it for a long time. And then one experience in labor and delivery, I was like, changing course completely.
Yeah,
I
I
have
always forget that you did ER before because I've
Yeah.
always known you in L&D, so I always
Yeah.
forget about that.
Yeah. So I'm board certified in both. So ER and labor and delivery. So I love both of those. ER I think will always be like my first love, but because I do love drama. I do love drama. So and I love the kind of, I guess, the instant gratification of, the quick turnaround, saving people and stuff. But there's a lot more that goes into it that kind of burns you out for sure.
Yeah.
I have a question in here about The question says, curious about your feelings on the cold bed for NICU patients. It saved my youngest. So I think that, whenever I came into labor and delivery and I had some of my first codes and I hear, they're putting them on a cooling blanket, I was like, what is that? Because I knew in the ICU with adults, sometimes they do that. Can you talk about what that means and what that is and why we do it?
Yeah, so that's a really interesting question. We actually, just like she said, we have this cooling blanket that we'll put babies on for 72 hours. And it's really babies who have an interruption of blood flow to their brains. So, a difficult delivery, um, and it can help protect their brains. It's really effective kind of for the more mild to moderate cases. If it's a really severe case, it can help, but it's less likely to. Um, but it's interesting because it's a therapy that's used in the adult world, and it's been around for a little while, and then it kind of made its way into neonatology. But the really good thing is that it gives us a therapy for babies that do have a difficult delivery.
Yeah. And she said that he's 12 now and he's doing amazing. So it
Wow,
definitely
that's so
helps him
awesome.
for sure. So do you, on the ones that are more severe, do you do it anyways, just in
We
case it
do.
helps? Yeah.
Exactly. Yep. So kind of unfortunately, at least right now, it's our only real therapy for that kind of a thing. I'm really hopeful in the future we're going to have other things to kind of layer on top. But for now, it's like really our mainstay. So we will, any baby that qualifies, we'll put them on the cooling blanket. And it can help in severe cases. It's just less likely to.
Yeah. And it's interesting that you say like maybe in the future you hope to see that kind of thing. One of my questions that I have written down was, what is something that you've seen during your time as a neonatologist that's kind of like a newer thing, evidence-based care, that has been a change that you've seen actually help
Yeah,
patients?
so funny enough, a lot of the big things happened just right before I started. I say right before, but maybe even a decade before, because we're looking at surfactant, which helps the
Yeah.
lungs expand and open. Antenatal steroids, which of course you know all about, is another thing that's been really pivotal for neonatology, but those things were before me.
Hmm.
And actually, this cooling therapy is the thing that really was kind of up and coming when I was doing my training. So we were doing some of the studies on that. And that's really exciting because, before that, there just really wasn't a treatment for it. So that's definitely been, probably the biggest thing, for me in my career is getting to be involved in some of those early studies. Um, and then there's some other really new cutting edge things that I got to be a part of, which haven't really hit mainstream yet. One of those is using umbilical cord blood, actually in these cases where kids are on the cooling blanket, giving them back those umbilical cord cells. But that's not mainstream yet.
Yeah. How does that work? Because I'm just imagining, we do delayed cord clamping. For those of you that don't know what that is, when a baby is born, we don't clamp the cord immediately if we can help it. Um, Sometimes there are situations in which we have to, but it's nice if we can let that baby get all of the extra blood that's in that cord to kind of give them back their extra volume. But how would you do it later on?
Yeah, so they basically at the time of delivery, they'll take that umbilical cord blood, and it kind of goes through this really big banking and purification process, and then gets given back to the baby as a transfusion. Um, but it's really cutting edge. It's definitely not for prime time yet,
Yeah.
and we'll have to see if it even helps. Some of the early studies showed it's safe and it may help, but we don't know for sure yet.
Right. Right. That's interesting. So do you think that'll become mainstream or no?
It's tough to say because it's been about 8 years since we did that first study.
Yeah.
But things take a long time to get through the whole process.
Right.
Um, so I'm really not sure yet.
Yeah. So what kind of schedule do you have? Because the doctors that I know don't have a great schedule.
I knew you were going to ask me that question. This is the most complicated question because we actually cover two hospitals 24/7. Um, and so we have a 9-week rotating schedule. And so some of the weeks I'm on 7 days in a row during the day, which makes for a long week. The only good thing is that there's no overnights during that week. And then we have other rotations where we do like 5 days in a row, and then we're off on Saturday, but we'll do a Sunday night overnight call. And then
Mhm.
other weeks where we'll do 2 or 3 overnight calls. And the overnight calls are 16 hours from 4 p.m. until 8 a.m. Um, we actually do have a call room. It's like the size of a small closet that has a bed, so we can go in and sleep for a couple of hours. If Jen isn't calling me, I get to sleep.
That's right.
If there's no deliveries to go to,
Mhm.
or if things are going okay in the unit, um, and then of course we'll get up for deliveries or for new admissions.
Yeah. So, my one of the questions that I also have is I love watching you talk to families. And I know that a lot of people on this live have never met you before, don't know anything about you. But if I was to talk about you to someone else, yes, you're an amazing doctor, but the first thing that I would say is what an amazing communicator you are with these families who are really scared. And that's something that I try to get better at every single day. Have you had, experiences growing up or anything that kind of caused you to really focus on being really good at that? Or is that something that you just are fantastic at already?
Well, it's nice of you to say that because it often doesn't feel that way. From my perspective, when I'm talking to
Yeah.
families, of course, I'm trying as hard as I can to communicate as effectively as I can.
Mhm.
But sometimes it's really difficult because you just don't know the outcome or you're trying to work through the care plan. And someone will say, will my baby be okay? And you're trying to answer the question with a lot of hope, but also balance that with kind of the realism. Um,
Mhm.
and so I think I'm really lucky. Like I said, my mom is a nurse. I'm watching the way that she has talked to people over time. I think I've really got that influence. Um, and I think I try really hard, to be as empathetic as I can and kind of put myself in, the family's shoes, which of course I haven't been in their same situations. Um, but I do have, a wife and 3 children, so I've kind of, certainly had my own stresses along the way as well.
Yeah, I've got nurses on here who also work with you who are echoing what I'm saying and that it's yes, I agree 100% Jen on how on how you are with patients. And I'll say coming over from the ER, I had a really good working relationship with the doctors and coming into labor and delivery, it's not always that way, but I was just floored. The first code that you and I ever worked together, I just saw how gentle, I guess you were with the conversation, and calm and not acting like, oh my gosh, everything is a huge, obviously it was an emergency, but not relaying your stress to the family. And I think that's so, so important. And so I really appreciate that as a nurse. And, because when you leave, a lot of times the nurses are left to deal with kind of the aftermath. And sometimes in the ER, it's like, you have cancer. Bye. And then we're left to, pick up the pieces. And it just makes it so much better and so much easier for that family to have that initial good connection with you so that they feel like their questions are answered right there. And we just love that about you for
Oh,
sure.
thanks. It's one of those things where, I really appreciate that. And often it just doesn't feel that way, because
Yeah.
things are, of course, stressful and there's a lot going on. And, like I said, too, it's like really hard to kind of, get that blend of realism and hope, because
Hmm.
it's like you never want to take away hope from anybody. We never know what the outcomes are going to be. I mean, we have our experience and we have our, textbooks, and we've seen these things a lot of times before, but you never really know what an outcome's going to be. I mean, babies
Hmm.
surprise us all the time.
Yeah. Um, so Christina asked, what birth defects are the hardest, or I'm guessing trauma or, situations at birth are the hardest to stabilize in the NICU?
Ooh,
So like what are some things that if you hear like, oh, this is what we're dealing with, you're more like, ooh.
yeah, that's a good question. So one of the things that's really difficult is something called a congenital diaphragmatic hernia. Um, And it can be different sizes, so, but in a more severe case, basically what it means is that the diaphragm is incompletely developed. And so the intestines come up to where the lung should be. And so you can have a lung that's like literally the size of a grape. I mean, it's so tiny. And so you just don't have a lot of lung to work with, and you have to be really, really careful not to pop a lung. Um, and so sometimes you'll have it happen where they say this mom's here and this kid has CDH, and you think, okay, this is that can definitely be stressful. um, and then of course another really big one too is any kind of significant congenital heart problem. That's always stressful as well.
Yeah, for sure. There's lots of questions coming in here, so I'm trying to make sure that I'm keeping up. A lot of people are just saying like, "Oh my gosh, I know somebody that had that," or talking about their own experiences. Do you have any experience with vanishing gastroschisis?
Ooh, that's a good question. And of course, when you ask that question about difficult things to manage, there's so many,
Hmm.
different things that you could bring up, like an omphalocele or a gastroschisis. Um, I'd love to hear from the person who's asking that question. It sounds like it's as a gastroschisis that they must have seen when the baby was in the womb that then had resolved and gone away.
That's
Um,
my favorite kind.
right.
The kind that goes away.
Any problem that goes away is perfect.
Yeah. Yeah.
I'm assuming that that's what she's referring to. We definitely see it from time to time.
Yeah.
Um, but babies with gastroschisis and omphalocele, where the intestines are coming out of of the abdomen, can be really difficult too.
Yeah, definitely. Let's see. A lot of people are asking about, do you know about this? Do you know about this? So we'll try to we'll try to stick to some, because I feel like that could lead us down a really big rabbit hole. Um, let's see. I will go to let's talk about your book. Why do you think that telling these stories is important? Because I have
That is
my own thoughts about my own stories, but I would love to hear why what you think about why it was important for you to tell these stories.
Yeah, that's a good question because, of course, I sat down and wrote the stories, and then I feel like after the fact, I'm sort of trying to figure out why I wrote the stories and why is it important to write the stories. Um, you know, Part of it to me is almost honoring these babies and these stories and, letting the world know who these babies are, because a lot of these stories, I think, they're all real stories and they're real babies, and every single situation is different. But I think it also helps communicate with the outside world that the NICU exists, and this is what families go through and that babies go through. Because I think so many people, just really aren't aware of the NICU and what we do. Like sometimes, I'll tell somebody that I work in the NICU, and they go, "Oh, that's so wonderful! You get to work with all the cute little babies." um, which is true. The babies are awesome, but unfortunately, it can be complicated, a lot more complicated than that.
Hmm.
And so I think, in a way, a book like this kind of helps communicate to people, what families go through. I mean, the families go through so much, and the parents are so strong, um, to go through this. And I think that my hope is that this book will show people that. And then another part of it too is that I'd like to convey to families how deeply we care, because when you read the book and you realize, we take these things home with us and we really think about them and we worry about them. Um, it's not like a 9 to 5 job, where you just sort of like punch in, punch out. When I'm driving home, when I'm driving in, like in the evening, I may be tucking my kids into bed and kind of, thinking about a baby and thinking about, what I can do to help them, or even just worrying, did we make the right choices? So I think part of it is to try and show like our humanity too. We get stressed, we get tired, we get, we get worried about families and babies. But I'm not sure that it always shows at the bedside. I hope it does, but I don't think it always does. I mean, I think that there are are families that might wonder at times if we really care, and if we're kind of investing everything we have in their babies. Um, and so, yeah, I kind of hope that writing shows that we do.
Yeah, and I think that's a good point about, a lot of people don't even kind of realize that it exists. Like if you ask them, of course they, yeah, it exists, but you know, anyone who comes to have a baby is going to go through labor and delivery and postpartum, always. A lot of people have no experience with the NICU whatsoever. It's kind of like you have a destination, you're driving down 220 to get to your destination, and there's an exit over here that you don't have to go down unless you're running out of gas or something. You have no idea what's down that exit. You can just fly past and not even know what's there, but it does exist, and there's a whole world over there that you don't even see. Um, and so I think that is important for people to understand because, sometimes we have people who have no risk factors whatsoever, and everything is perfectly fine and normal until it's not. And they experience a NICU stay that they never anticipated, and it's kind of like a different kind of trauma that doesn't have to do with like, oh, my birth plan didn't go as planned, or it's a different kind of thing. Like, I'm not going home with my baby yet, and that can
Yeah.
be super, super scary for people.
Yeah, can I turn that question around on you just
Yeah,
because I'm interested to
sure.
hear what
Yeah.
you would say. Why do you think it's important for healthcare workers to share our stories?
So coming from the ER, I had a really hard time sometimes with, I guess, not being able to let it go, you know? I was lucky in that my husband also worked in the ER. So if I came home and said, oh my gosh, this happened, he could kind of have this like mental image of what's going on to really understand. But I remember uh like I had a 6 year old trigger warning for SA. I had a 6 year old that had been assaulted by her father. I just came home and like I'm talking really violently assaulted down there. And I just came home and I couldn't get up off the floor. Like it just so truly rocked me. And I feel like if I wasn't able to talk about that, that it kind of just eats away inside of you. And I think that especially now during this pandemic and, healthcare workers are burnt out, um, mental health is really suffering. And I think it's cathartic to be able to share some of the things that we go through. And we see some of the most intense moments in life in general. And so to not be able to share that can be really almost like bottling up, all of these things that inside your head, you know. And if you're not going to therapy and you don't have somebody close to you that you can really confide these stories in, I just feel like it kind of can make you um, almost eat you from the inside out,
Yeah, and I
with
think
good
it
and
helps.
bad.
Yeah, and I think it helps for us to get to read other people's stories too, because it kind of helps us realize like that's been actually a lot of the feedback from the NICU nurses. It's like, wow, I didn't realize that you felt this way. I feel this way too. You get this whole different connection that we didn't have before I wrote the words and before they read those words,
Yeah.
because it's hard to talk about, and you're at work and you're just kind of doing your thing. Um, but it's been really interesting to hear people's response. And of course, I have the same response to other people's books when I see, how they kind of approach different things and the way that they deal with it.
Yeah, and I really appreciated how, and I've told you this before, but like how well you're able to use your words to kind of transport me into the room with you. Like I can see in my mind's eye what you're seeing and feel what you're feeling. And I feel like that's why it was so easy for me to get emotional reading your book because it feels like I'm there, you know? And I just feel like you truly have a gift in your writing that you're able to do that because not all people can do that to make you truly feel transported to where the story is happening.
Thanks. Yeah, I mean, it's definitely a process to try and get that, but I appreciate it because it definitely it's a lot of work to try and get there.
I'm sure that it is a long, long process. Um, Paige asked, does your hospital have a NICU parental advisory board? I sit on ours in Wilmington, North Carolina.
You know, those are the greatest things, and we don't exactly have one. We have the Family Support Network that has a lot of parents who have gone through the NICU on, you know, on staff and as volunteers, and then we work with them. I would actually like us to have an advisory board. I think that's going to be one of the things that we're going to put together in the pretty near future.
What kind of things do they do?
Well, so they do events for families. So they'll do like, you know, a dad's pizza night, like a mom's craft night. They'll go by bed to bed and meet with the families, you know, offer support, bring by reading materials, educational materials. Um, and then actually one of the good things that Family Support Network will do as well is sometimes they'll come to us as well and say, hey, you know, this mom is having a really hard time with this particular thing. And they'll also do mentorship things. So, for example, if a baby needs a G tube, sometimes they'll set that family up with another family who had a child with a G tube, you know, previously
Hmm.
as a mentor. So yeah, a whole bunch of stuff like that. But I think that having an actual advisory board would be good as well.
Yeah, I mean it's good to have that perspective because as healthcare workers we know our side of it inside and out, and there are pitfalls that we may not see, or I'll just say areas of opportunity that we may be able to better support people in if we know kind of what their perspective is for sure.
Yeah, that's
Um,
totally
I've had
true.
I've had a few questions about how COVID has affected the NICU. Like, what is the pandemic? What kind of effect has that had on your experience there?
Yeah, it's an interesting question because, you know, at the start of this, of course, we had no idea like what was going to happen. You know, we thought actually that preterm babies were going to get really, really sick with COVID. Um, and thankfully, that has not been our experience. Although, unfortunately, we've had a lot of moms who have been really, really sick with COVID. And then, of course, you know, that translates into sick babies and babies that are born prematurely. Um, you know, because of mom being sick.
Hmm.
And then we've had just a really small number of babies who have tested positive. And those babies have not been, we don't think that they've been sick from COVID. You know, they've been more sick from like their underlying, you know, birth issues or mom being sick. Um, and then, but another way that COVID's really affected us is just staffing, you know, the number of
Mm,
staff that are out with COVID. You know, so running the unit has been really difficult as well.
yeah, and also I know that we had, and I think, yeah, we were together in a situation where the mother was positive, and so then that has an effect on who can see the baby and when, and how traumatic that can be to not be able
Yeah,
to see your baby just whenever you're sick
yeah,
your own self. So but you
yeah. Of
cannot
course, you're
put those
bringing up
babies
like
at risks.
yeah, like a really big thing that I had, you know, hadn't just mentioned, which is the fact that families can't come and visit while they're in that isolation period. Which I mean, it's just a huge amount of stress, you know,
Mhm.
on families, and it's tough.
Yeah, definitely. My next question is, I have a lot of new nurses who follow me. And a lot of the questions that I get in particular as a nurse, who has been a nurse for 10 years, is how do I approach a physician if, I myself am afraid of that I'm wrong. And you are different in that, like, I feel like there's so many people who feel like they could approach you. But being in the physician world, I thought it would be interesting to get your perspective on advice for new nurses on how to communicate with physicians.
Yeah, that's a great question. I am a very, very strong believer that the way to keep patients safe is for us to communicate and listen to each other. So I believe a nurse should be able to come to anybody, anytime, and say, I don't understand this, or I'm concerned about this, or I have more information about this, you know, whatever the case may be. And I think that everybody should be receptive to that. whether it's hospital administration, physicians, other nurses, leaders, whoever it is, should be responsive to that. Um, I do think that, it definitely helps me if it's like sort of a direct thing, so if somebody says, I'm concerned about this situation because of this and this, it certainly clues me into, okay, they're worried, there's a safety issue, and it seems to be this thing. I mean, that always helps, I think. Um, Especially if people are busy or if like, yeah, they're rushing it. It definitely helps to have that really direct communication. Um, but I know it can be intimidating, and I know that some people honestly are just jerks when you bring something
Yeah.
to them,
Yeah.
um, and I think that makes it really difficult. And it's really difficult when you're new. Of course, I've been in the same situation when I was going through training, having to interact with people. Um, and I think sometimes you just have to say, I'm going to do the right thing. I'm going to bring up this concern and I'm going to
Hmm.
say it. And whatever happens, happens. But at least I know I did what I could. I stood up for the patient and I said whatever the concern was. And then at that point, the hard part, especially for me, is you just sort of have to let it go. If
Yeah.
you get, like if you get a rude response or something, you have to like
Hmm.
just water off a duck's back,
Yeah.
just let it go. I did
Yeah.
my job.
And
Um,
you may have had some scary interactions with uh like really experienced nurses because I know that
that's
coming in as a resident, nurses can be pretty rough.
that's right. Like the OR techs and the nurses, like
Oh
especially
yeah.
NICU nurses,
Yeah.
can be really intimidating.
Yeah.
Um, so yeah, it's true. I mean, it's difficult when you start out, um, but I think you just have to do your best and just, I think that it always helps when you get to know the people that you work with.
Mhm.
I know that's not always possible, but it definitely helps.
Yeah.
Um, but I honestly, I think we just need to listen to each other because, if a nurse comes to me and says I'm concerned about something, like I'm concerned.
Hmm. Tisa said it's probably you that we're talking about. I mean, probably her that we're talking about. That she's the one that we'd be scared of.
That's right. Yeah, I don't want to cuss Tisa. Just
No,
kidding.
nobody does. Nobody does.
Tisa's
So,
awesome.
and for those of you that are just now joining, I do want to make mention of exactly who this man is and what we're doing. So, this is Dr. Ben Rattray, and he is a neonatologist or a little teeny tiny baby doctor. And he wrote a book called When All Becomes New. And so we are here. He's answering questions for us. So if you have any NICU questions, doctor questions, or just questions for him in general, we are getting those answered. I've had a lot of questions about your family. So I know you said you had 3 kids.
That's right. 3 kids.
And
Um,
what do they think about what you do? Do they have like a true understanding of how old are they?
yeah, so I have 2 daughters and a son. My youngest daughter is 9, my middle daughter is 12, and my son is 15, and he just
Hmm.
got his driving learner's permit.
Oh
So
no.
there you go. Um, yeah, and of course it's interesting because they've all kind of grown up as I've been doing this, and they've gotten pretty used to kind of hearing discussions at the dinner table about sick babies and like what's going on.
Hmm.
Um, I asked my son if he wanted to go into medicine, and he was like, "No way! You work nights and weekends, and like I don't want to do it." My middle daughter will like literally pass out if she sees blood or needles, so I don't think she's gonna do it.
Yeah.
Um, and yeah, so I think, and that's fine. I mean, I think the thing about medicine is like it really has to be a passion and a calling
Hmm.
for people to do. So I definitely would not encourage anybody to do medicine unless it's what you truly, truly want to do.
Yeah. I've had people say to me, especially since they know that I'm a nurse on TikTok, I'm thinking about being a nurse. I might want to. I'm like, you better know before you get into this because it is no joke, especially right now. It's so tough to be in healthcare right now,
Yeah,
but
I
also
agree.
so rewarding. Like the things that make it rewarding are still there. It's there's so much extra stuff that goes along with it now, and you and I, in the way that we work, are shielded from a lot of the COVID stuff that goes on. But it still affects us in, like what you said, the staffing and the visitation and stuff. So it is very difficult to be in healthcare for sure right now.
Yeah, but I think you're right. A lot of the good things are still there. You know, we still get to
Hmm.
interact with our patients. We still get to make a difference. Like all that stuff is there, but it's just a little more complicated right now.
Hmm. Definitely. So I had a question from someone who was asking, how can they support someone who has a baby in the NICU? So, like, if they have a friend who um, is having a stay in the NICU, how can they support that friend?
Yeah, I think one of the things is just to listen, you know, to them. And you know, they may want to talk about it or they may not. Like they may want to just kind of sit in silence or they may just want somebody, you know, who's just going to be with them. Um, One of the things that I heard from somebody, and I can't remember, you know, who or where it was, but instead of saying like, "Can I bring you a meal?" It's like, I'm going to bring you a meal
Hmm.
and drop it off on your front doorstep at 5 o'clock on Tuesday.
Hmm.
You know, something like that, where you're like really just stepping out and you're just doing it. Um, you know, I
Yeah.
think something like that could really help. And then
Hmm.
actually a huge one is if they have other kids, just offering to watch those other kids so that they can spend time at the hospital.
That's one
I
that I
think that
wouldn't
would
think
help.
about, but that's really important.
Yeah,
Yeah,
yeah.
because those kids cannot come up to the NICU. Before COVID, were kids allowed in the NICU?
They were. It depended on flu season. So, like when
Okay.
we got into flu season, 12 and under could not. But during the non-flu season, it's so weird in this pandemic. It's like I feel like I can't even remember how it used to be. But we did actually have kids in the NICU.
Mm, gotcha. I got a lot of talk in the chat about age of viability. There was a mom in here. I'm trying to go back and see. Um, oh, this is so sad. So this was a long time ago, but she had a 1 day shy of 27 weeks, so 26 and 6. And they told the mom that they were too young to try to resuscitate. And she was talking about how awful that was because the baby was crying and oh, so sad. But the question that I've seen asked a few times is, what is the age of viability? When do we intervene?
Yeah, as that's a good question. And as the person who was just sharing that story said, it shows how that's actually changing over time. You know, because like for example, JFK's son, I always forget how old he was, but he was about 36 weeks or so.
Hmm.
And he actually he died from respiratory distress syndrome, you know, because they just didn't have the ventilators, they didn't have surfactant. So things have really changed. So now that number has gone all the way down to 23 weeks. Some centers are trying to push it to 22. Unfortunately, the outcomes at 22 are, you know, really, really difficult. But some centers are trying to go to 22. Um, the place where we work, we're using 23.
Yeah.
You know, of course, it's a really rough road at you know, 23, 24. Oh, somebody wrote in Patrick Kennedy, exactly. I just saw one in the comments. Um, but yeah, that's right. So all that to say, you know, it looks like things are kind of changing over time. One of the big questions though is at some point, you know, you sort of just bump into a wall that you just can't go any lower.
Yeah.
Um, I don't know over the course of our careers, you know, how much things are going to change. We definitely struggle, you know, at 23 weeks.
Yeah. And I've definitely been a part of conversations where we're so close. We're so,
Mhm.
so close. And then we have to have those conversations with family members. One of your colleagues was really great and had I had a very angry father. This baby was imminently going to deliver, and we were like 22 and 4. I just remember we were really, really close. And, having to sit down face to face and say, like, we're so close, but we're not there, and that's really hard because you're breaking people's hearts, and it's not that we don't want to save them. It's just that, you know, we can't. And that's really hard to tell people.
That's right. It is one of the most difficult things because, of course, as in healthcare, we want to jump in and do everything. Um, but we also know that at some point we're doing so much harm,
Mhm.
because, there's so many really significant bad things that can happen. Um, and to put families through that, if the chance of a good outcome is really low, it's really difficult. But some centers are definitely trying at 22 weeks.
Yeah.
So that's, definitely pushing the frontier.
Yeah, definitely. Along with this like ethical, I guess, conversation, I had a question because this happened a few weeks ago where I had an experience with this, and I was wondering like what do you do in this situation? So um there are certain cultures and certain situations where the parent may not want to revive or resuscitate a baby that has the potential to be resuscitated. How do you approach that?
Yeah, so it's always a really difficult thing. And I'm actually seeing a comment too, so I'm going to jump
Yeah.
back and then forward where somebody
Okay.
said, it's difficult for parents to understand when they hear at another center they resuscitate 22
Hmm.
weekers. I think
Hmm.
that's a really good point, and I think that, we should we should always offer transfer if it's something that we feel like our center can't do,
Hmm.
either technically or ethically, but somebody else can do. It's definitely something that we can offer transfer. Um,
Hmm.
and then I'm almost forgetting your question because it related, which was, oh, exactly, which was ethically.
Ethic.
So,
Yeah.
so
Hmm.
one of like the central tenets for ethics is, once is about 50%. So like, for example, say you have a 5-year-old kid with leukemia, and they have a survival chance if they get chemotherapy that's like in 95 plus. If the parents refuse chemo, you can actually go to a judge and say, this child would have a 95% chance of survival. If we gave them chemo, we think that they should get the chemo. And in that setting, the judge will pretty much always agree with the medical team in that case,
Hmm.
because, there's such a good chance for a good outcome. Um, and so that's certainly the case for us. So say, for example, somebody came in and they were 28 weeks pregnant and they did not want us to resuscitate the baby. Ethically, that would put us in a really difficult situation because, that baby would have a great chance of a good survival. Um, that's not the case at 23 weeks. And
Hmm.
so, you're sort of like um, going through these different gestations, looking at survival statistics, trying to figure out, where do you get to that 50% mark? Um, and it's interesting that you say it because it doesn't come up for us very often. Most of the time, parents are really just wanting us to do everything.
Hmm.
Um, but I think for some parents, if they're truly, truly did not want their baby to be resuscitated at 28 weeks, I just don't know that they could be in the hospital because it just puts us in such a difficult
Right.
ethical.
Yeah. Yeah. The situation recently was a term baby that came out not doing okay.
Oh,
And
right.
so it was a shock, like, what do you mean? Because and I think it was more of a cultural thing that the dad was like, it's okay. No. So yeah, I would that was the first time that I'd ever heard someone say, like, it's okay, you don't need to save the baby. Um, so yeah, I was like, what do we even do in that situation?
Right,
Um,
right.
so
Yeah,
I
and
don't
I think really that's when you use that rule, of
yeah,
if the baby has a really good chance of survival and a good survival, then
yeah,
ethically we do intervene.
right.
Yeah.
Yeah, definitely. Let's see. I have some more here. Um, do, do, do. What would you tell a younger version of yourself? Like having
Oh,
seen all that you've seen, done all that you've done, what age would you go back to and what would you tell yourself?
you know what I would tell myself? So it's sort of like a a cheating answer, you know, because when you're young, you don't know that everything's going to be okay, you know.
Right.
But for me, um, it was like, it was hard to get into medical school,
Hmm.
like really hard, really stressful, a ton of rejection. And, you know, I was able to get into medical school. And then I was actually able to get to Duke and do training, which was like, you know, a big achievement, considering how difficult it was to get into med school and kind of get going. Um, and you know, along the way, like it's been okay. You know, it's like writing this book took me 6 years. I had tons of rejection from literary agents until I finally found an agent. You know, and then we had rejection from publishers, and then we finally found the publisher. And like all along the way, it's just like it's so difficult. You know, going through training is so difficult. So the thing that I would want to tell myself is it's going to be okay.
Hmm.
You know, the hard part though is that for some people, like some of these hurdles end up being, you know, too difficult to get over. But I still have this belief that people end up in the right place. You know,
Yeah.
so like if you're a new nurse and you don't get the first job that you wanted, you're gonna find an awesome job and you're gonna find your place. Um, and then the other thing that I would say too is a lot of times like you land in the right place, you just don't know it at the start. So like
Yeah.
the publisher of this book, it wasn't the publisher that I would have picked, you know.
Hmm.
I would have picked like a top New York City publisher, you know, like Scribner that publishes Anthony Doerr, like that was what I was shooting for.
Hmm.
And we got rejected from the, you know, by that editor. I was super excited to actually have the chance to send it to her, but you know, she rejected it. Um, but the publisher that I ended up with is like the perfect fit for me.
Hmm.
So that's what I would tell an earlier version of myself.
Yeah, I think that's such a good message for everyone because there are so many things, especially working in healthcare and being a family in the NICU, like just knowing that eventually, you're not going to be in this space anymore. Where you feel this sense of dread and rejection and all that stuff, which ties in perfectly to this next question. Jess asked, "Can you talk about PTSD and the NICU?"
That is a great question because, you know, I feel like in the past, I don't think anybody thought about it or talked about it. And I think over time, we're really becoming a lot more aware about it. Not only in parents, I mean, of course, it's the most significant in parents, but we're also realizing people that do this as their job end up with PTSD, to some extent.
Mhm.
Um, and so I think that, you know, it's really significant. You know, like you hear these stories. You know, of people that like they can't drive past the hospital, they can't, you know. And actually that's one thing that, you know, I would say about this book is I don't recommend the book for people who have had babies in the NICU, especially if they've had a difficult time. I think that, you know, it's interesting actually because surprisingly for me it's turned out that some people have reached out and said it's helped them in their healing journey, which is awesome. And I would hope for that, but I also wouldn't necessarily recommend it. um, I do think PTSD is a really big issue, in parents, and I think it's one that we are not adequately addressing. You know, we don't have psychologists on staff in the NICU the way that we should. We don't really have the follow-up mental health that we need. Um, so I think it's a big area that we could improve on.
For sure. And I have I have someone saying that she's due in April and we're scaring her. No, no,
Oh
no.
no. So
Do you have any words of encouragement for pregnant people at this time and anything like that?
yeah, so here's the thing. Like almost all babies do really, really well. You know, like we're just seeing, you know, the small fraction of babies that have, you know, some difficulties. And then the other thing is a lot of the babies that we have in the NICU are in for, you know, really treatable things that they just need some support. So for example, if mom has diabetes and the baby has low blood sugar, we can treat that and we can have great outcomes and it's not a problem. You know, or, you know, a lot of the you know, babies that have some degree of prematurity, you know, we can support, we have really great outcomes. Um, so I know that, I know there's a lot of stress involved. I actually kind of felt like with my three kids, like I would have liked to have been knocked out while my wife was having the baby and then just wake up like 2 days later and they say, hey, your baby's great,
Yeah.
because it's stressful, right?
Yeah.
But the good news, honestly, is, you know, babies do so well.
Yeah.
And so many babies don't come see us in the NICU.
Definitely. And I think I also would love, because I've seen some questions about this, like for pregnant people, what are some things that they can do, I guess, to prevent seeing you? Maybe is there anything that people can do to prevent coming to see you?
Yes and no. A lot of these things are out of your control, and a lot of moms have a lot of guilt about, having a baby in the NICU. And the
Hmm.
thing that I feel like I'm always saying is like, you did nothing wrong. There's nothing you could have done to prevent this, which,
Hmm.
really is true. Um, I mean, I think all this stuff though, like, just taking your multivitamins, getting kind of the rest and exercise, following like whatever OB recommendations there are, um, definitely do those things. But also know it's not your fault. Like sometimes these
Right.
things just happen, and we are there all the time to take care of you. You know, it's just what happens sometimes.
That is exactly right. Ashlyn wants to know, what do you struggle with most in your job?
Ooh, gosh, that's a good question. I think the thing that I struggle with the most is, I think, trying to adequately communicate with parents, is always challenging because you're trying to give them the right information um, and then some of the medical decisions are just difficult too. When you have a baby who's not responding very well to your ventilator changes, you're turning up the blood pressure medicines and they're not responding the way that you want to. Um, it's just really, it really makes you worried. And sometimes I just wish I had a job that like it just didn't really matter. Like I could just go in and like, make cups of coffee, and if I messed it up, it doesn't matter.
Right.
Like, you know, um,
There's no eternal significance in the coffee. Yeah.
right.
Yeah. My kids are getting antsy. So I have a couple more questions. How do you recharge? Like, what do you do to kind of keep going? Because I know, especially with your schedule and stuff, it can be a lot all at once. Like, what do you have any hobbies? What kind of things do you do to recharge?
Yeah, so I mean, I like to just, mainly spend time with the kids and with my wife. Those are like the number one things, just, spending time together. I love to, get out and go for a hike. Um, we actually have like an old small sailboat on a lake. And so we like to take that out and go sailing. That's always really fun.
That is fun. What lake do you
I
go
didn't
to?
make that. We go to Smith Mountain Lake. I didn't
Okay,
make
yeah,
that
yeah.
sound very good. Like an old small
Old,
sailboat,
small.
but
Yeah.
it's it's good. It's fun.
Yeah, that's amazing. I actually had my graduation party on Smith Mountain Lake. I went to my college was in Lynchburg, Virginia, so it's kind of close to Smith Mountain, so I know exactly where it is.
It's a beautiful
Um,
lake.
it really is. What can moms? What ways can moms help with depression when their babies are in the NICU? So a little bit of postpartum depression. Are there some things that moms can do for themselves?
Yeah, so unfortunately, I'm sort of the wrong person to ask in the sense that I don't have that formal training. I think that there are a couple really important things, though. One thing is if you truly have postpartum depression, to talk to your OB,
Hmm.
because there are medicines that you can go on. There's therapy for you. And if you have true postpartum depression, you really do need to reach out and get help. Um, if you don't have postpartum depression, but you're just having a difficult time, I think getting out of the NICU and doing some of the things that we know are helpful for us, like talking with friends, going for a walk, like reading a book that's not my book. I think getting out of the NICU and doing some of the things that we know are helpful for us, like talking with friends, going for a walk, like reading a book that's not my book, like read a Nicholas.
Oh no, he left. Uh-oh. I don't know where he went. There he is. Can you hear me? Are you there? Oh, oh no. Okay, so yeah, I had a patient reach out to me and was struggling with postpartum depression, and the thing that I want you guys to hear is it is not normal, but it is common. And so please, please, please reach out to your providers and let them know that you're feeling this way. So, yeah. And this was the time that we were going to end anyways, but thank you guys so, so much for being here. I'm very, very happy that we were able to do this. I do want to remind you that his name is Ben Rattray, or Benjamin Rattray. And he has, his book is When All Becomes New on Amazon. I'm going to try one more time to get him online. I don't know if it's going to work. All right, sweet buddies. Well, anyways, I just want you guys to know I am in the bed. I want you guys to know thank you so much for being here this evening. And on behalf of Ben, I know that he would say, thank you so much for being here. Go buy his book, When All Becomes New, on Amazon. And you can find it by going to the link tree in my bio and clicking on Jen's Favorite Things on Amazon. You'll see books. I'm sorry you missed it. I'll try to put this on YouTube, maybe. We would still be going, but I think his connection got cut off. So. All right. Bye, guys.